Mujib Medical University, Dhaka. Our speaker for today is Dr. Varsha Shah. Madam is consultant histopathologist at Royal Point Hospital, UK. The topic for today is benign lesions of breast. Madam will give a small talk on benign lesions of breast followed by slide seminar. The students for today are Dr. Abhirami Radhakrishnan from AIMS Kochi, Dr. Ashwini from AIMS Patna, Dr. Lavina Manu from St. John's, Dr. Lakshmi Mewalal from Bareilly, Dr. Partha Sekia, Dibrugarh, Dr. Purva Kalsaria from BJMC Ahmedabad, Dr. Shraddha Muller, BVMC Pune, Dr. Amita from BSMMU Dhaka. The moderators are Dr. Jaiti. My screen has freezed.
Just
Hello.
yeah, click on the screen and then you can move ahead. I think just click on the screen and then is it?
Yeah. So moderators Dr. Jayati Datta, she is a consultant histopathologist, and Drs. Tribedi and Roy, diagnostic labs. Myself, Dr. Shalaka Satpute, consultant histopathologist in Kokilaben Hospital. Our webinar hosts are Dr. Anita Borges, Madam is consultant pathologist, Center of Oncopathology, and Dr. Sumit Kushal. A few reminders for everyone. A few disclaimers. A few more disclaimers. A reminder on the upcoming talks. On 11th of October at 7 p.m. we have a lecture on malignant lesions of breast by Dr. Chinoy. On 13th of October at 7 p.m. we have slide seminar on malignant lesions of breast by Dr. Dilip Giri. With this, we start today's session. Dr. Varsha, madam, you could start sharing your screen.
Yeah. Hopefully you all can see my screen, yeah?
Yes, ma'am. Yes, ma'am, it does.
Okay. So today's topic is the benign breast lesions. So this is the outline how I'm going to do. First, I'm just going to talk about benign epithelial lesions of the breast and then move on to how to approach breast needle core biopsies. Just to briefly reiterate the anatomy and histology which you all learned day before yesterday. So this is the collecting duct here, then lactiferous sinus, segmental duct, subsegmental ducts, and then we have terminal ductulo-lobular units, or also called TDLUs. And most of the breast epithelial proliferations arise from TDLUs. So here is the normal histology of the TDLU. So we have terminal ductule, and then we have the lobules here. And both the ducts as well as the lobules, they are lined by inner epithelial layer, and then there is outer myoepithelial layer. Usually the cells of the myoepithelial cells are kind of vacuolated. And just outside the myoepithelial layer, there is a thin basement membrane, which is very difficult to see on H&E, but can be highlighted by special stains for the basement membrane. And this is kind of highlighted by the CK5-6 stain, which would stain the inner epithelial cells patchily, as well as it will stain the myoepithelial layer as well. So what exactly is hyperplasia? So with any stimulus, when you get uncontrolled proliferation, it leads to hyperplasia. But when you remove the stimulus, it then reverts back to normal proliferation. In contrast with in neoplasia, you get uncontrolled proliferation with stimulus, but when you remove the stimulus, the proliferation continues. So these neoplasias could be either benign or malignant, and I'm only going to talk about the benign ones today. So this is the latest WHO classification of the breast tumors, benign breast tumors. So we get benign proliferations we have, which are hypoplasias. We have adenosis and its variants. And then we have, we have, we have adenomas and biphasic tumors. So first I'll talk about the benign lobular proliferation. So this is just a schematic diagram of the lobular proliferation. So this is simple adenosis, that is sclerosing adenosis. You can get a cystic change within adenosis, and you can get apocrine metaplasia within adenosis. So basically in simple adenosis, you get expansion of the lobules and increased number of lobules. So under the microscope, so that's normal. And that's the expanded lobule with increasing number of the acini or the lobules. So this is simple adenosis. And again, simple adenosis will be lined, glands will be lined by inner duct epithelial layer and outer myoepithelial layer. So again, it's the same immunoprofile as the normal. In contrast, what is sclerosing adenosis? It is a variant of simple adenosis. So what happens that there is a fibrotic stroma between the acini. That stroma starts compressing the glands. So these glands become very atrophic. So that's why you get sometimes you get linear arrangement of the cells. But the typical nature of sclerosing adenosis is that it is a lobulocentric proliferation. So under low power, you will still appreciate the normal lobular architecture of the sclerosing adenosis. So that's the high power. Again, you can appreciate that the normal lobular architecture is well preserved. And that is another example. Again, you can see there is a kind of normal kind of lobular architecture with streaming of cells here. Same again here, and you can appreciate how the glandular structures have got compressed by the fibrotic stroma, and then cells are literally kind of arranged in a linear pattern, mimicking invasive lobular carcinoma. But because sclerosing adenosis is just a variant of adenosis, the outer myoepithelial layer is still preserved. So if you do myoepithelial markers, for example, P63, it will highlight those myoepithelial cells. So there are some glandular epithelial cells here which are not stained by the P63 stain, but the myoepithelial cells are stained by them. So that is the difference between if you are really stuck, is it invasive lobular carcinoma or is it sclerosing adenosis? Then you can confirm it by P63, which will highlight the myoepithelial cells. They would be absent in invasive lobular carcinoma. Apocrine adenosis is another variant of adenosis where the ductal epithelium, the inner epithelial layer undergoes apocrine metaplasia, and again the myoepithelial layer is well preserved. And within the apocrine lesions, we have a spectrum. So we have simple apocrine adenosis, atypical apocrine adenosis, DCIS, and invasive carcinoma. Between simple adenosis and atypical adenosis, the nuclei become atypical. They are almost 3 times the size of the lymphocyte. Sometimes it is pretty difficult to differentiate atypical adenosis from apocrine DCIS. But in apocrine DCIs, we will get marked expansion of the lobules, as well as there is necrosis, and you will find some mitotic figures as well. So you are basically looking for necrosis and mitotic figures to make a diagnosis of apocrine DCIs. So now moving on to intraduct proliferation as opposed to lobular proliferations, you can get usual ductal hyperplasia, atypical ductal hyperplasia, and ductal carcinoma in situ, which I won't be covering today. So this is just the schematic presentation, benign, atypical, and malignant, which could be in situ or invasive. So we have a normal here, and usual duct hyperplasia. So what's the difference here? What happens in usual duct hyperplasia is that both this inner epithelial layer as well as myoepithelial layer both proliferate. But the proportion of epithelial cells versus myoepithelial cells may vary. So you may have more epithelial cells or you may have more myoepithelial cells. While in DCIS, only the inner epithelial layer proliferates, and it is the neoplastic proliferation is opposed to UDH. But the outer myoepithelial layer does not proliferate. So what happens that when the duct gets expanded, these myoepithelial cells may become very atrophic, particularly in high-grade DCI. Sometimes you may just see interrupted layer of myoepithelial layer. So that is the difference between UDH and low-grade DCIs. And then obviously invasive, the cells break through the basement membrane and becomes invasive carcinoma. Like in other organs, if you can see the basement membrane, then you can say it is invasive carcinoma, I mean, it is broken through the basement membrane. But because in the breast it's very difficult to see the basement membrane, we use absence of myoepithelial layer as a surrogate marker for invasive cancer. So in DCIs, in situ carcinomas, you do have this peripheral myoepithelial layer, while in invasive carcinomas, there is absence of peripheral myoepithelial layer, with a notable exception, which is microglandular adenosis. So just to kind of highlight this, CK5-6 in normal, you have presence of outer myoepithelial layer. In usual ductal hyperplasia, there is inner epithelial layer proliferation and the preservation of the myoepithelial layer. In DCIS, the inner epithelial proliferation is CK5-6 negative, it is neoplastic, while the outer myoepithelial layer stays with CK5-6 and is preserved. And here in invasive cancer, we are not seeing any myoepithelial cells. So this is the spectrum of ductal proliferation. So we have benign here and malignant here. I'll come to this B category a little later, which we use in the UK. And we have another category, which is called ADH, which is atypical ductal hyperplasia. So what exactly is atypical ductal hyperplasia? It is a neoplastic proliferation. The cells are identical to low-grade DCIs. Morphologically or genetically or immunohistochemically, there is absolutely no difference between the cells of low-grade DCIs and ADH. And the ADH term is reserved for low-grade lesions. Once it is high-grade, you can't call it ADH. So it has to be low-grade neoplastic proliferation. So we have certain criteria of when do you call it ADH. Either the duct is only partially involved by this neoplastic epithelial proliferation. Like here we have some usual hyperplasia, but here we have some neoplastic clonal proliferation of low-grade epithelial cells. Or, so this is the qualitative criteria or the architectural criteria. Or you can have quantitative criteria when it measures less than 2 millimeter, or involvement of less than 2 ducts are completely involved. We call it ADH. So basically, ADH is nothing but underdeveloped low-grade DCIs. So there is morphological overlap, immunohistochemical overlap, as well as similar genetic profile. So now coming to usual duct hyperplasia, which I told you about, that there is proliferation of both epithelial and myoepithelial cells. And here we have a cribriform architecture. So your differential diagnosis is not in typical cases, but sometimes it can be confused with low-grade DCIS. So how do you differentiate usual duct hyperplasia from low-grade DCIs? So they both have cribriform architecture. But if you look at the spaces, there are irregular spaces here, while here they are punched out spaces. So that is the difference in the architecture. If you look at the cells now, because there is proliferation of both epithelial as well as myoepithelial cells, you will get a different population, dual population of cells here, while here you will get a monomorphic population of cells because it is only the inner layer which is proliferating. The cells will be streaming. Here there will be nuclear overlapping, while here they are kind of evenly spaced out nuclei. There is no nuclear overlapping here. And then if you look at the bridges or the bars, they are kind of very rigid. They are not tapering bars. while here they will be tapering bars. You can sometimes get a little bit of necrosis in usual duct hyperplasia. That does not exclude the diagnosis of usual ductal hyperplasia. And also you can get occasional mitotic figures. So both these features, if present in small amount, do not rule out the diagnosis of usual ductal hyperplasia. You have to rely on the other morphological criteria. And then if you are really stuck and you can't differentiate, is it the usual ductal hyperplasia or is it low-grade DCIS? Then you do CK516, which is mainly cytoplasmic. It is a high molecular cytokeratin. So you can either use CK56 or you can use CK14. It's a cytoplasmic, mainly cytoplasmic staining, invasive membranous staining. It does not stain nucleus. It stains benign epithelial cells and myoepithelial cells. Remember that it also stains myoepithelial cells. And this is typically negative in malignant ductal epithelium. Okay, typically, I'll come back to it a little later. Why I said typically, not always. So, what do you see with CK56? Because it is typically positive in benign epithelium, negative in malignant epithelium. So we have CK56 positivity here. It may not be uniformly positive. You may get just patchy positivity. While here in DCIs, the CK56 is negative. Again, it may not be always completely negative, particularly when it is papillary DCIs. You may get scattered myoepithelial cells here and there. It doesn't rule out the diagnosis of DCIs. And again, as you can see, there is a preserved peripheral myoepithelial layer. So that is usual duct hyperplasia where I showed you a cribriform pattern. Now this is a different pattern. It's called micropapillary hyperplasia, or it's also called gynecomastoid hyperplasia. Because typically this type of hyperplasia you see in gynecomastia. So how do you then differentiate? Obviously, your differential diagnosis is micropapillary DCIS, right? So how do you differentiate the two? Now on morphology. In micropapillary hyperplasia, you have broad-based papillae. First of all, there are no true papillae. There is no fibrovascular core either in this or in here. But the base is broad, and the papillae over here, they become kind of as if somebody has pinched the top of the papilla. So they become narrow. So the broad base and narrow papillae is micropapillary hyperplasia, while just the opposite in micropapillary low-grade DCIs or high-grade DCIs, you get broad bulbous papillae. So the base is narrow, and the papillae at the top are bulbous. Okay, that's the main difference morphologically. And then obviously, if you look at the nuclei, they will be more evenly spaced out, just like low-grade DCIs. There may be prominent nuclear layers, while here there will be more overlapping. And if you see the bars or the bridges, they will be tapering type, while rather here there would be rigid bars. So that's the difference between micropapillary hyperplasia and micropapillary low-grade DCIs. And because it is hyperplasia, if you do high molecular weight cytokeratin, you will get the staining for patchy staining for cytokeratin 5-6. While in DCIs, it would be negative. Now, if you use any immunostains, you have to know what it stains normally, what are the pitfalls, and what type of staining to expect. So CK5 is what are the caveats? As I said earlier, that it is typically negative in malignant ductal epithelium, but it can be negative in some of the benign epithelia. So when you get apocrine metaplasia, and you are trying to decide whether it is DCIS or it is just hyperplasia, CK56 is not going to help because CK56